So Alexey, there are lots of new drugs being explored in mantle cell lymphoma, and I think we could give a symposium over several hours on all of them, given all the data. But we have lenalidomide, ibrutinib, acalabrutinib, bortezomib all approved. Then we have novel anti-CD20s, we have venetoclax, we have some data with PI3 kinase inhibitors, although that's been more limited, I would say, in mantle cell, CDK4/6 inhibitors. I'm going to get to Steve and CAR T cells in a second because I want to hear his experience there. But as far as the other types of agents, tell us what you think are some of the more promising things that people need to know about, and perhaps if they have access to a clinical trial, they may want to pursue that for their patients.
Yeah, absolutely. So I think it's becoming a very exciting field. Certainly, ibrutinib resistance is one issue, and I think we are making some headway there in addressing that. So venetoclax, as you mentioned, it's the drug which has now been approved in CLL with deletion 17p. So it's a BH3 mimetic. It's not a kinase inhibitor for a change, which is an exciting mechanism of action. So, and it has been studied in mantle cell lymphoma, and there's close to several dozen patients enrolled in the study, and the data in heavily pretreated disease looks fairly similar to what ibrutinib does, with progression-free survival of over a year and complete response rates of over 60%. So different mechanism, very exciting data. So there's data in CLL that venetoclax works post-ibrutinib, so the expectation is it would work post-ibrutinib in mantle cell lymphoma. And John mentioned combination trials, which I think is the way to go in this disease. In terms of phosphoinositide 3 kinase inhibitors or PI3 kinase inhibitors, so the study with idelalisib single agent was somewhat underwhelming. Response rates were 40%, and the duration of response was about 3-4 months. However, PI3 kinase inhibition is very important in lymphoma in general, and there is a lot of preclinical data from Cornell, from other centers, which demonstrate that ibrutinib resistance is actually dependent on PI3K signaling in many cases. So I think it's still a promising field, and there are several agents in that field. So the PI3K delta inhibitor idelalisib, so gamma delta dual inhibitor duvelisib, and then umbralisib, which is a delta inhibitor and also concurrently inhibits CK1, and the latter is also in studies in combination with ibrutinib run by Dana-Farber. So still a very exciting field there. In terms of palbociclib, the CDK4/6 inhibitor, actually, from a scientific perspective, one would think that it would work great in mantle cell lymphoma. However, single-agent responses are fairly underwhelming, under 20%. But again, there is very good preclinical data which suggests that it might abrogate some of the resistance pathways to ibrutinib. One area where it would be nice to have a dedicated drug is NF-κB signaling. So ibrutinib resistance in part relies on NF-κB. There are BRC3 mutations, TRAF2 mutations, all within the NF-κB pathway. And then abnormalities on PIM1 kinase and ERB4, so all NF-κB pathways. So it would be very good to have a dedicated NF-κB inhibitor, but that has been quite elusive so far.
Get to the end of the pathway.
So Steve, you were part of our study. GR1 presented lenalidomide rituximab as upfront therapy. Do you think that with all of these agents we are approaching chemo-free sort of strategy, which is more a technical descriptive term than anything, but you espouse the intensive approach, but
well,
then...
no.
So
let me say that I espouse getting people into a deeper remission as possible up front, because PFS is important in this disease. All the studies we're talking about, by the time they're able to be analyzed, they're essentially going to be retrospective because we'll have new agents. So, when it comes to survival. So I'm for PSF. Now, with regard to Gia's study, which I think is fantastic, and I have a number of patients still on it 5 years later, that was very instructive. So this was a study in mantle cell lymphoma where we treated patients up front with lenalidomide and rituximab. an astounding high upfront CR rate, but 5 years later, 2/3 of patients still on therapy. Not bad. And I want to tell you that the patients I put on that trial were the same kind of patients that I would have given chemotherapy to. They needed treatment. They had advanced disease. These were not indolent lymphomas. So how do I make sense of that result, okay? And I'm thinking that, again, this is theoretical, that this is a genetically unstable disease. And if you can postpone having to use cytotoxic chemotherapy agents and get them to respond, you may get a very durable response. And of course, you know, lenalidomide by itself is not mutagenic, and Rituxan, neither is Rituxan. And I think that these patients maybe have benefited because we've not given them agents which may, in the setting of an unstable genome, you know, lead to some mutation that turns out to be bad.
So I think it opens the door for at least looking at these combinations, whether it's the 2-drug or the 3-drug or different 2 drugs.
Or non-DNA damaging agents as first therapy for this disease. We may
It was
find out.
interesting that in the R-square study, you had a subset of patients that had a molecular CR as well.
Yeah.
So that was very interesting.
Yeah.
It is astounding, and I think it also sets the world's record for the number of oral presentations at ASH. She's had like 3 or 4.
Just 2. I would be remiss knowing your work in CAR T cells. Just in a nutshell, where do we stand with CAR T cells in mantle cell at this point?
So, the CAR T cell I work with is the T-Gen Laclusil Novartis CAR T cell. They licensed the technology from Penn, and I've only treated a couple of patients, so I can tell you, and I don't have adequate follow-up to give you a big picture, except to tell you that you can achieve complete remissions in patients that are treated with extensive disease. I mean, spleens and packed bone marrows and in bad shape. So it's active. Andre, I know, is running a trial as well. I don't know if it's probably follow-up is still immature, but I'm sure he's had the same observation.
We don't have the data reported yet, but it will be submitted for ASCO. But the CR rate, what I can share, the CR rate seems even more promising than in large cell lymphoma. So this being said, we had some patient, we see the toxicity profile that we know about CAR T cell now. I had one patient who did really well with grade 2 and in CR and doing well. And we treated 4, 5, 6 patients. But one of the patients came with a blastoid variant with this is a poor guy who came from out of state, and then he had 1,000 skin nodules, and then had seen every drug, and including ibrutinib, obviously, responded, but didn't last. But definitely this is a proof of concept, and I think this is going to be part of the therapy in mantle cell.
So John, before we wrap up, your sense of kind of the maintenance sort of future in mantle cell lymphoma, because I think that with all of these oral agents, there's going to be the ability to keep people on these drugs long term. Obviously, those minor but chronic toxicities, sometimes more severe, but often nagging, the expense, other issues. Do you think that we will have defined durations of therapy? Do you think it will be you achieve MRD, you go a little longer, you stop it, and then restart it? What do you see the future of maintenance when we start talking about the combined therapies?
Well, I think you hit on the most important thing, and that is how do we figure out when we can stop these agents and not necessarily continue them as maintenance indefinitely. You know, there are some patients I think we'll figure out that need that, but hopefully we'll find out that most patients can be stopped at some point based on some probable molecular evidence of minimal residual disease negativity, and then the fact that they could be retreated perhaps with the same agent once they relapse. So maintenance is, in my mind, going to become less popular with indefinite therapy as opposed to more popular as we move forward. And that's important for patients too. Now, they love their remission. They're going to want to do whatever it takes to maintain it. But if they also know they can maintain their remission and get off of the drug at some point, if they become MRD negative, and then understand that they can be successfully retreated, that's got to be the strategy we need to move forward on.